I'm Howard Stupak. I practice mostly facial plastic surgery. I do have a disclosure. I have a patent royalty-related relationship for the nasal valve device that's described here. A lot of my practice has actually become related to nasal obstruction and functional rhinoplasty, and that's really what gave me a real strong interest in the nasal valve and how to fit it better into my practice and how to let it work better in my practice. And really, I started to ask myself some questions to find a way to make this nasal obstruction, nasal valve thing fit better in my practice. And question one was, are we getting enough improvement from septoplasty and turbinate reduction alone with patients with nasal obstruction? And I think that's the most common combination of procedures. The question is, in the majority of patients, is it really enough? And then on the other extreme, do we ever avoid doing more extensive external nasal valve surgery or valve surgery because we feel like it was too much? We didn't want to put the patient through too much, so we just do septoplasty and turbs without having to go through open rhinoplasty type situation. And then how are we going to make nasal valve surgery work with insurance? How can we work on this to improve our insurance revenues? How can we do the coding right? How are we going to fit this in when traditionally a lot of this was cosmetic or cash paying things, or you had to use rhinoplasty codes that insurance companies automatically see as a red flag. So how are we going to work this when you want to work nasal obstruction and nasal valve surgery into your practice? And these are questions you can ask yourself. So I became really passionate about my interest in this part of the nasal valve and started to work on developing and revising some procedures, and that's how we came up with this ALAR, endonasal cartilage repositioning technique. And you can see the stent that's in position. It's between the upper and lower lateral cartilage. And what this procedure does is, unlike some of my frustration with some of the previous procedures, grafts are not required to be harvested or implanted, no implants, which is usually the other alternative. Open rhinoplasty approach was not required. And I'll discuss this towards the end, we found some good insurance codes that correlate perfectly with this procedure and has been tested to work. And what you're doing, and the whole procedure, is based on repositioning the cartilage, first freeing them up from each other, and then re-supporting them until they can scarify in a new position. So what you're doing is you're releasing the cartilage, you are repositioning it. By creating a raw surface between them, you're scarring them into a new supportive position and securing the internal and external nasal valve. And there it is from endonasal view, and I'll show a video as well. So who can use this in? Patients with general nasal valve obstruction, age-related nasal valve collapse, trauma. You can even use this as part of the multi-level CPAP or sleep apnea treatments that we've been discussing, or even to help with CPAP compliance, get better airflow through the nose. Where do I not like to use this? The patients where I've had this procedure not work is where there's too much cartilage removed. So you can't reposition cartilage that doesn't exist, so it makes sense that this procedure is not to be used in a revision rhinoplasty where there was a lot of reduction, or even where it was excessively complex and made the cartilages not in a really normal position. So my caution is not to use this in complex revision rhinoplasty. And here's that same nasal valve slide. That blue arrow is pointing to a green region between the upper and lower lateral cartilage. That's where the scroll area is. And until recently, that's not really been thought of as a common area of nasal obstruction or nasal valve collapse. But when you really think about it, that is a pivotal area in the structure of the sidewall, because if the upper and lower lateral cartilage were not properly supporting each other, they basically collapse in, and I'll show a nice slide of this. And you can see it from the base view as well. A lot of times upper internal and external valve collapse, even though we think of them as two different things, they go well together. So why is the nasal valve important? It's really getting that airflow behind the palate. So here's a patient where you can see both on the patient's right side, you can see both internal and external valve collapse. You can see that middle third of the nose where there's internal valve collapse. You can see the nostrils smaller, and a schematic view of the collapsed cartilage and a severe endonasal valve collapse. If you just put your speculum right in before looking first, you're going to miss a lot of the exam. So we usually do a caudal maneuver or a Q-tip modified caudal maneuver where we can dilate the external valve, and you could even see in the bottom picture the internal valve as well. And you can sometimes lift the tip and play with things to diagnose better. And this is the diagram that I like to see that explains why supporting the two cartilages supporting each other creates better airflow. There's some collapse if they're not supporting each other, where you see the overlap failure. When you can get them to support each other, there's laminar airflow, and you can strengthen the sidewall. Same thing in another schematic. So how do we do this procedure? It's actually a fairly simple procedure, and really the attractive thing about it was that you can do it in conjunction with septum turbinoplasty without specialty training and really concentrating on open rhinoplasty and perfection of grafts and all the complexities that go with it and the cosmetic changes. It all starts with an intercartilaginous incision, and then really dissection between the cartilages to free up a sliding surface. And here's a video of the procedure. So you have your nasal speculum in there. If you look carefully, you can see the caudal border of the upper lateral cartilage. The speculum is dilating the valve open. I'm using a sawing-like motion to open that intercartilaginous incision broadly. You use a Stevens tenotomy scissor then to undermine over the upper lateral cartilage. If you notice that there's a lot of not much bleeding, this is a cadaver study. So I wish I could say it was all skill, but it's a cadaver. Then we retrograde undermine over the lower lateral cartilages, which is on the right side. And you can see that, especially in this cadaver, you can see these cartilages are mobile relative to each other, and you can see how the valve can be dilated. And I'm kind of manipulating it so you can see what the eventual goal is. So the stent or the device itself is ethibond suture harnessed to a specialized nasal valve splint. And we're passing the needle end of the device through the upper lateral cartilage. You got to get a good bulky bite. Make sure that goes through. And you can see it's fairly part of our skill set as nasal surgeons to be able to do this using a speculum. There's the device with a slit and a kind of a hole on the end, and I'm passing the needle back through the device. This is external to the patient, obviously. And then we're sliding the whole thing back in, and you can see where the knot is that connects the suture to the device. And then if you see that slit, that's going to be our cleat or cinching to hold things in place. And you see I bent the wings down for a better spring-like position and better locking. So this is you don't really need to tie this. You put the device into position, lock it down, and if you see when you lift the splint up and lock the suture into the splint, the cartilages become better approximated and can heal in position if you keep that for 7 to 10 days. Not a huge cosmetic change, but you get slight nasal rotation, very slight, but it's not a terrible change in procedure. We also, in this patient, did septoplasty and some bony work up top as well to her dorsum. From the front view, you can see a dilation in her nostril size and some tip rotation and improvement in symmetry, because we also did septoplasty as well. And again, from the base view, before and after. An endoscopic view, this is actually a different patient, but you can see the change in the endoscopic nasal valve. So again, I do this usually in conjunction with septoplasty turbinate reduction. I leave the support device in for 10 days to allow the scarification. It allows simple placement in the OR, removal in the office, and it allows knotless placement. I use a safety knot sometimes, but it's not necessary. So in conclusion, nasal valve, in my opinion, and it sounds like a lot of our opinion, is it's important in nasal obstruction. No grafts or implants required in this procedure. No open rhinoplasty. Simple and aesthetically acceptable. Thank you so much.